Welcome to part 2 of this series. To get the most out of this training, I highly recommend you watch the videos in order. In part 1, I examined the scope of the issue of sexual assault and discussed why survivors avoid the dentist. I defined trauma and how it changes the brain, and described how patients with a history of sexual assault or trauma can present to us. In part 3, I'll go through practical tips and strategies for before, during and after appointments. This aims to enhance the quality of care for our trauma patients, all while looking after ourselves in the process. Now for part 2, where I'll begin by discussing the trauma-informed dental care skill set. After this, I'll look at the traditional approaches to managing dental anxiety in the context of the trauma-informed approach. Finally, I'll address how to respond to a disclosure of a history of sexual assault. The current evidence-based best practice approach for treating survivors of sexual assault and all traumas is called trauma-informed care. My hope is that this will become an integral part of dental practice in Australia and around the world. It involves a change in attitude, ensuring that abusive dynamics are not unwittingly replicated. Trauma-informed care is defined as a shift from caretaking to collaborative ways of working. It's a movement from an illness or symptom-based model to one of skills acquisition or strengths-based. The question, "What's wrong with you?" becomes, "What happened to you?" The model is doing with rather than to or for patients. There is so much evidence for trauma-informed care. I'll share just one study with you here, an anaesthetic study conducted in Harvard in 1964. It's a randomised trial of a supportive compared to a non-supportive manner in a preoperative visit by an anaesthetist. The supportive group received a short consultation, talking and answering questions. They halved the dose of opiate required postoperatively. The non-supportive group didn't have this consultation and needed to stay in hospital 2.7 days longer. Trauma-informed care has beneficial effects across the board for patients. There are proven results, for example, in surgical outcomes with wound healing and infection, rates of recurrence of cancer, and more. The benefits offered to practitioners are just as profound, connecting us to the humanity, joy and satisfaction of clinical work. I believe that trauma-informed care needs to be a universal precaution. As we know, dentistry is hard for most people, not just these extreme cases. It can only do good for those without a trauma history. It's not necessary for a patient to disclose a history of abuse to us for us to be able to help them just as well. And most of the time, survivors don't want to bring it up with the dentist, so don't probe. It must be up to the patient's comfort level. Healing from trauma involves 3 phases. Phase 1 is safety and stabilisation. Phase 2 is processing. And Phase 3 is integration. For more detail, please see the Blue Knot Organisation's practice guidelines I have linked to at the end. The great news is that the process of healing from trauma is the experience of compassionate care. This triggers a powerful biological response which affects gene expression, stress reactivity, immune system function, and more. Neuroplasticity allows healing to occur, and trauma can be completely resolved. The brain changes I discussed earlier are not necessarily fixed for life. Research on the role of oxytocin in pain mediation and experience shows that the quality of the relationship between the patient and clinician has an impact on the level of pain patients feel. As dentists, we can help our patients learn new life skills. For example, helping survivors regain a sense of control about what happens to their bodies. And the example from the beginning with my patient Anna and her self-worth. The 5 foundational principles of trauma-informed care are safety, trustworthiness, choice, collaboration, and empowerment. I have applied these to dentistry and dentist-patient interactions. Firstly, safety and trustworthiness. Trust is critical for patients to regain a sense of control. If we think about it, survivors have usually been victimised and betrayed by people they trusted who claimed to care about them. They have been used to unequal power balances, have minimal or no experience of relationships without a winner or loser. They have difficulties distinguishing between safe and unsafe relationships, not been seen, heard or understood in the past, been subjected to violation, exploitation and dual relationships, believe they are undeserving and expect to be harshly judged. Therefore, for trust and safety, we as dentists must try our best to do the following. Avoid assuming anything about a person's past or experiences. Stay non-judgmental, avoid being critical, and accept people fully. Look out, because the way patients hear and perceive what we say and do has likely been altered by their trauma. For example, a patient walks in, the receptionist is on the phone, and they may interpret this as being deliberately ignored. Be aware that your tone of voice really matters here. Acknowledge that choices are about survival and make sense given the past. For example, if someone tells you they smoke, avoid showing obvious judgmental disapproval. Validate feelings and check that you understand them correctly. This also encourages emotional self-awareness in the patient. Pay attention to our own feelings and use our ability to self-regulate. For example, staying calm models this to patients. Communicate as clearly as possible. Follow through on commitments and promises. Be consistent with what you say and do. Trust begets trust, and we have to earn it. For example, if you say the drilling will take another few seconds, stop after this time. Strongly believe in the patient's ability to cope well. There is evidence for more success when you do. Be culturally competent, sensitive to gender, ethnicity, sexual orientation, age, and all dimensions of difference. For example, immigrant or racially diverse communities are already marginalised in a dominant society, and so are often extra cautious about revealing problems. Making more of an effort to be welcoming really helps. Knowing patients' beliefs and attitudes to healthcare helps build rapport and eases anxiety, which enhances the quality of your care. Boundaries are particularly salient. Boundaries of survivors have been blown. Therefore, we as dentists have to take much more responsibility for maintaining them. For example, the capacity to realise they can say no to things may be reduced. Setting very clear limits within the relationship helps the patient create boundaries. This is healthy for everyone. We must ensure that patients don't experience boundaries as punitive. Be kind and respectful when you explain them. For example, I'm sorry, I just don't do house calls. Boundaries are maintained for patients and to look after ourselves. Working with trauma can be very demanding. To illustrate the concept of boundaries, here are several clinical examples. Firstly, from my experience, patients often ask for or expect things beyond the realm of what we do. For example, working way outside normal hours for something that isn't urgent, or not paying for treatment. I have found that it is very easy to overgive as dentists. Often the patient won't be aware you've done anything more than usual. Therefore, we must set limits on what we will and won't do. For example, how long we are prepared to spend. An example of maintaining healthy boundaries with a patient is asking them if it's okay to talk about a topic and asking permission before touching them. We need to find out what is and isn't okay with each individual patient, what they need. Next up, a critical boundary to highlight for male dentists is to resist the urge to go into father mode. When you present your boundaries to patients, as much as you can, find ways to do it without a paternal edge. Survivors have told me this is what rapists do to try and calm them during an assault, so it can be a big trigger. If you are a male dentist and much older than your survivor patient, be aware that this too could trigger memories. Even if the woman is an adult now, it doesn't mean she's fine. When memories are triggered, she can be taken back to when she was 5 years old. This brings her back to feeling judged, easy to confuse, and full of shame, especially if you display upset. Know in that moment you are speaking to a scared 5-year-old. You may even notice an inappropriate sexualized response from her. As you can see, there is a delicate balance with you as the dentist giving the patient full autonomy, but realizing you are not necessarily dealing with the adult you are looking at. I know it's not straightforward, but it's very important to be aware of these possibilities. The final example of boundaries is to honour the resilience of your patient. They have survived after all, and we are one of many experiences that can trigger memories for them. So resist the urge to be a superhero knight in shining armour and save them. For example, avoid offering yourself up for something you can't deliver, or making promises that you don't keep, like saying you will call the patient and not following through. Still regarding trust and safety, empathy is essential. How do we cultivate empathy? Check out Brené Brown's work on empathy and shame. It's important to take at face value and really believe the perspectives and experiences each patient describes. This has not been encouraged in this area until very recently. In my experience, patients often report authoritarian and judgmental reactions from previous dentists. I'm sure you've also heard this. We have to triple our empathy for survivors of sexual assault. There is a difference between empathy and compassion. Check out Paul Gilbert's work. In summary, empathy is understanding how someone feels and imagining how that might feel for you. It's a mode of relating. Compassion starts with empathy and couples with other attributes like sensitivity and the ability to cope with distress. These are then taken into action to alleviate the suffering. The trauma-informed approach is all about compassion. To summarise trust and safety, we must be clear and consistent between what we say and do. Being non-judgmental, culturally competent, and accepting patients fully with empathy are all critical. We must believe in our patients' ability to cope and plan appropriate boundaries beforehand. I know that was really dense, so here's the ocean. Empowerment and choice. Survivors have been helpless in the past, so an empowerment approach is critical. Target strengths, not deficits, with positive reinforcement of choices that bring a patient closer to their goals. For example, if a patient reduces the sugar in their coffee from 4 spoons to 3, congratulate them on this progress. Educate on the links between the trauma and things they are currently struggling with, such as flossing. Self-defeating behaviours are understandable ways to survive past events and their impacts. This is one intention of the survivor videos, which I encourage you all to watch. The aim is to regain a sense of control. To achieve this, discuss all choices, the potential outcomes of the choices, avoid telling people what to do, explain reasons for everything, and be totally transparent. I know this is standard practice, but it has a much greater significance here. It's critical for recovery that we demonstrate to survivors our belief that it's possible to heal. The old idea of never being good enough or permanently broken or damaged blocks healing. A lack of this understanding is triggering, re-traumatizing, and very, very common. Here is a clinical example of this from real life. How many of you have had this happen? You sit the patient up after an exam and say there's a tooth or several teeth that have caries and need restoration. The patient becomes dejected, sighs, and makes a comment like, "I knew it," or "typical," or "what's the point in trying, there's no hope." They take this news as yet another confirmation that they are broken. It's depressing for us to see that the patient has given up. We must remind patients that they can get back to oral and general health, that we will work with them to achieve this over time. It's worth putting in the effort, and there is hope. Next, collaboration. Survivors don't feel heard by clinicians. Patients tell me this all the time, and I'm sure you hear it too. As dentists, we must ask questions and keep an attitude of openness and interest. Identify individual triggers that lead to the fight-flight response and address them together. Model a calm, regulated state. See people in the context of their lives, how they've got to where they are now, and work with that. Be patient and sensitive as you work through any anxiety and tension. We are working together to move towards patient goals. It's an equal partnership. The patient and dentist both bring their experience and understanding to the relationship. It's not an us as experts and them who we fix. Survivors have spent their whole lives adjusting to fit others, to their families, workplaces, everywhere. It's easier for us to adjust a bit to accommodate them. Patients are still triggered, but reactions become smaller and smaller as you work through it together. An example from my experience is patients needing less and less time. They just come in relaxed and ready to go. Another scenario is patients who come in, sit on the dental chair, and have a big cry. After a few appointments, this also usually passes. It's a process and a journey. We can't assume everything is fixed after the first breakthrough with a patient. Realistically, old reactions will still get triggered, but don't let it discourage you from the longer-term goal. Collaboration also applies to working together with other professionals and services. We need new pathways for communication. For example, developing a working relationship with a team of allied health professionals like GPs, community health nurses, counsellors and student welfare officers from schools. To summarise the trauma-informed principles, trust and safety are established by being true to your word, careful consideration of boundaries, and full acceptance of all aspects of patients with empathy. We must discuss all choices and their potential outcomes, and demonstrate our belief in patients' ability to heal from their trauma. This empowers them. We are collaborating in an equal partnership for success in achieving treatment goals. I want to pause at this point and say that I understand that you may be feeling overwhelmed by all of this. I realise that there are time constraints and business realities in the private practice setting to factor in. I know that dentistry is hard enough without all of these extra considerations. I want to let you know that from my experience in private practice, setting up the relationship and building trust and safety do take extra time, but mainly initially. Once established, treatment times are not very different, and you have great and very loyal patients who you really look forward to seeing. Dentists have said to me that this population should only be seen in the public sector due to the extra work and complexities involved. Consider that this is perpetuating and worsening the problem of isolating survivors and confirming that they are not welcome and don't belong. I can reassure you from my experience that if you do the right thing by people, the money will take care of itself. The anxiety management techniques that we use every day include systematic desensitization, tell, show, do, distraction, mindfulness, and relaxation. These all work in really well and complement the trauma-informed approach. They are all based on rapport, interactivity, and the patient gaining control. This builds their confidence and trust. So it's no wonder that evidence has shown the most powerful predictor of a good outcome is the strength of the therapeutic relationship. In fact, research by Jerry Kent from the University of Sheffield shows that high levels of anxiety and phobia don't simply reside within the individual or their perceptions of dental care. Anxiety and fear are located mostly within the relationship with the dentist. He found, from the patient's perspective, that interventions can be conceptualized quite differently. It's not about the particular anxiety management technique. For example, after a CBT program, patients were asked what helped them to tolerate dental treatment. They said, the provision of information, the dentist understanding and listening to their concerns. the time taken, and being put in control by the dentist. As you can see, these are all based on the relationship, not the CBT. Triggers for dental anxiety were shown to include remarks made by the dentist. This was found especially when they were angry or made condescending comments. Patients complained that dentists made them feel guilty for being anxious. I hear this a lot. A different study by Moore et al. Found that negative dentist comments and behaviours were 5 to 10 times more likely to be reported by highly anxious patients. In summary, all of these results indicate that relationships are the most important thing, and that an interpersonal model of anxiety and anxiety reduction is most useful for dental fear. Trauma occurs in relationship, so it takes new relationships to promote healing, much like replacing any old habit with a new one. We can't tell which relationship may be the catalyst that sets a person on the path to healing. It could be us. Connection promotes healing, much like my patient Anna from the beginning. If a child discloses abuse to us, we must report it, but this is a different topic. Given that the most common reactions to a disclosure of a sexual assault history are very unsupportive, it's understandable that most survivors don't want to open up. Here are a few examples of these harmful responses and what not to do. Not believing that the abuse has happened. I find it hard to believe that your father would do such a thing. Are you sure you remember what happened correctly? Downplaying the abuse. It could have been worse, at least there wasn't penetration. Blaming the victim. Why did you let him carry on when you got older? Did you enjoy it? Minimising the impact of the abuse. It only happened a few times. You were too young for it to have much of an impact. A strong emotional response such as anger or disgust. It makes me so angry that this happened to you. This could be overwhelming for your patient and deter them from speaking to you in the future. Demanding or instructing a patient to take a certain action, rather than giving the person choices. You need to see a psychiatrist, or you must report this to the police. Avoid encouraging the patient to go into detail about the abuse. This may make the person vulnerable to overwhelming emotions. Focus on how the person feels about the disclosure and their current obstacles. Now what to do. Recognise the courage it took to disclose to you. It must have been very hard for you to tell me about this. Say that you are happy they trust you enough to talk about it, and that you are glad that they have told you. Believe. That sounds like it must have been terrible for you. State very clearly that you believe them and that the abuse was not their fault, no matter what the circumstances. Listen. Don't interrogate or ask questions beyond those necessary to find out whether they are safe. For example, asking, "Is there anything I can do to help you feel safe here?" Let the person speak at their pace and disclose only as much as they are comfortable. Do not blame or pass judgment. Suggest links between current issues or symptoms and the past abuse. This must be done with care, but can really help survivors overcome them. For example, you can ask, "Is there anything that makes you particularly uncomfortable that I need to be aware of?" Offer referral options. The decision must be made by the survivor. In Victoria, there is the Sexual Assault Crisis Line, or SACL, which is part of CASA. Australia-wide, counselling services are set up differently in each state. Please see the website links at the end to the National Sexual Assault and Rape Crisis Services, and have this information on hand to offer your patient. Pay attention to your own response and try to avoid expressing strong negative emotions like anger or outrage until after the patient has left. The person who has disclosed may not be able to recognise that your anger is directed towards the offender. they may think it's aimed at them. This could reinforce the abuse being a shameful or disgusting topic which shouldn't be aired. If you are overwhelmed with emotion, make it clear that your reaction is directed towards the abuse, not them. Consider that it is often frightening and terrifying for a survivor to be around someone who is very angry. Perhaps leave the room for a moment to compose yourself, but only if the patient is not left alone. You may need to debrief at a later stage. Think ahead of time about who you would do this with. It could be a work colleague, friend, family member, or professional service. Remember to keep patient confidentiality in mind when talking to people. All of this isn't as hard as it might sound. In summary, care and compassion are the most important things. Just say as much as you can comfortably. This concludes the second video, which I hope has been interesting and valuable. In the final video of this series, I will break down the dental visit and give you practical tips and strategies for before, during, and after appointments. You can use these immediately in your practice. Thank you for watching, and see you in the third video.